So the next person is Merit01026, and the title of the paper is Left Powerless, Qualitative Social Media Content Analysis of the Dutch Break the Silence campaign on negative and traumatic experiences of labor and birth. A very interesting paper. Merit, are you here?
Yes, I'm here. Thank you.
Thank you.
Welcome, Merit. This is unique because you have collected stories from the social media. And I was wondering whether this gives you a good cross-section, because there are many that are not posted, or maybe only the ones that stand out in some people's mind would be posted, and those that come up as near positive and normal will not be posted. So it may introduce a bias in your study.
Yes, thank you. And I think that's a really good comment. We also thought about that. What we see is that, of course, when an organization like this childbirth activist group who started the Break the Silence movement, they, of course, maybe attract a certain group of people, a certain group of women who also experience their birth in a certain way. However, we do also believe that there are a lot of women who would not be found when we are looking for respondents in normal research. So that will be maybe more, yeah, in like online they would be able to give their opinion, but maybe not in normal research.
So you did this very tough job of categorizing it. Yes, go ahead, please.
No, I was just going to ask about the potential for using social media for research, and sort of expanding on the prior question, the balance between accessing people you wouldn't reach otherwise and selection bias associated with that.
Thank you. Yeah, it's a really good point. And I think that's especially challenging with the new types of ways we can now collect data, but also reach other people, reach other stories that are already posted and not collected through official research. How do we come about, and how we can use that, and what are the advantages, but also the disadvantages about this, especially with the evolving technological opportunities that we have now. But if you look at collecting or reaching women to actually be included in research, you also ask them for a certain opinion, and if they're also asking that way and they put their story online, I think we can get really interesting insights in what they're feeling. But they actually wrote it in their own environment, their own safe homes, maybe, when they feel safe to share their story.
I think we will have to do a comparative study with a questionnaire study and a social media study to get to know, as my concern and Dr. Jean's concern is the same, how much do we attribute to the selection bias?
Yes.
But it is certainly a very novel way of research to look at, and that is what I must compliment you for.
Thank you, I appreciate that.
And also, did you go about looking for just, did you look specifically for positive stories as well? Or was it just?
Yeah, because this was based on the hashtag activism campaign Break the Silence. So these women were exactly or specifically asked for negative experiences with the care. Yes. But sometimes in the stories, someone mentioned like there was a really sweet nurse who cared for me. However, I also experienced this. So we did see some things that women mention out positively. But I did hear about that. Of course, it's good to know how women experience it, that it's less of a taboo around this subject, that women can speak out about their negative experience. But we also hear that maybe a positive hashtag activism campaign could also be really good to see where we can learn from what is good.
Absolutely. And the last point I wanted to make was that, would you want to derive a percentage by looking at the number of deliveries during that time period that you collected this information on social media around that time period? Would we be able to get a kind of a percentage of how many of these are negative experiences?
Well, based on my study, we cannot get percentages at all because it's a really specific group of women that felt that because of this action, they could share their experience. So these stories only give a valuable insight in the perspective of these women. However, we cannot say anything about how much it's going on. Therefore, we decided to do a questionnaire, a survey study that's currently being conducted in the Netherlands, and we have more than 9,000 respondents at this point. So hopefully we'll get more insight about the percentages and what's going on in the Netherlands.
Right. Thank you.
Can I sneak another question in?
Yes, please do.
So in what are probably your preliminary studies of those 9,000, are you getting a better sense of balance, or are those 9,000 surveys mostly focused on negative experiences? Let me put it in context. We do surveys of women on a regular basis, and we always include a question on what was the best thing that happened, what was the worst thing that happened. And it balances out, actually. It's somewhat similar in terms of the number of positive and the number of negative responses. How does it work in your context, given that the thrust of this was clearly around negative experiences, which are valuable to capture, but force you into looking only at one side of that picture? Do you have any insight from preliminary analysis of your surveys to get a sense of that balance, or even whether or not you're asking both sides of that question?
That's a really good point, and I also completely agree. It's really important we look at both sides. I do have to say that our survey is currently focused on the negative aspect. However, what we did is really set out the survey as a general survey. So it's really like share your experience matters. So it's nothing on the negative side of what's going on. So we really focused on 2 points. One was like what situation you may have encountered during your birth, not saying if it's positive or negative, and if you gave consent for certain procedures during the birth. And then in the questionnaire, they do get a question, did you experience your birth positive or negative? So it can also definitely indicate if it was good or bad. And then we will specifically ask about certain situation, but also about, did you receive support? Were you able to ask questions? So also in a positive way, but also in a more severe way that we also see as types of categories of disrespect and abuse.
It's very exciting.
Yeah, we are very excited, and to go and look at the results, and hopefully, yeah, it's good, and we see signals that it's going really well in the Netherlands, but also the things that we can improve. Because of course, like the study I did on the social media content analysis, we see things are still happening, and it's a global thing that's going on.
Thank you.
Thank you.
Thank you. It was really interesting, Marie. Thank you so much. May I go ahead with the second presentation, Dr. Mala and Dr. Jean?
Thank you.
Mm-hmm.
Okay, and we invite the next person, Ms. Bharti. The number is 0.028, and the title is Assessing the Awareness Regarding Childbirthing Process Among Pregnancy in Women Residing in a Tribal Area in Bandardana. I hope I'm...
Bandardana.
Bandardana.
Yeah.
Right. It's a little difficult name. Okay.
Yes.
We would love to hear what you have to say. So
Yeah.
5 minutes for you.
Thank you, ma'am.
Thank you, Bharti. I think, first of all, congratulations for venturing into the tribal area and doing
Thank
your
you, ma'am.
questionnaire survey. It's not easy.
Yes.
And it was heartening that 75% had an average knowledge of pregnancy. But I think one thing that came up from your study was there were a lot of multigravida in a very low age group. Is that correct?
Yes. Yes, ma'am. In tribal area in India, actually, early marriages are very commonly seen in tribal area. So that's why there is a grand multipara. We can see in below 30 only. I have seen 4 to 5 multigravida.
Right, right. Well, there's urgent need for you to also give them contraceptive advice in that area while you're doing your survey.
Yes, ma'am. I have already given the topic for my MSc students to go ahead with family planning methods in tribal area.
Mm-hmm, mm-hmm. And how many of these were institutional deliveries in tribal areas? Or were they?
Actually, only 30 to 40% they prefer for the hospital delivery or the institutional delivery. But now, Pravara Institute of Medical Sciences, they have started with mobile van as well as mobile bicycle. So that's why we have started now 70 to 80% institutional and hospital deliveries.
Oh, so that number has gone up while you
Yeah,
have
yeah.
been.
Yes, ma'am. Yes, ma'am.
That's very heartening. I think I wanted to know, how do you propose to increase the knowledge of pregnancy, childbirth, safety, uh,
Yes,
based on your
ma'am. Our
survey?
center, we have ANM and we are giving the training to them. So I thought I will do the antenatal mothers awareness. So I went there in tribal area and I have assessed their knowledge. First of all, Indian women, they are hesitating to discuss about childbirthing process. But I encourage them, I have talked with them and I asked them how you are preparing. So there will be their culture, their customs are different to give the childbirthing process. But when I enter in tribal area, I found that they are doing the non-pharmacology complementary therapies as we have discussed yesterday. So like breathing and their hard work is more, which gives the less pain during the labor. That I found out.
Easy
And
labor.
I assess their knowledge. Yeah, ma'am.
Mhm. Dr. Jane, you want to ask something?
My basic question is simply, what do you do with this now? How do you translate this into practice, into recommendations for practice?
Yes, sir. In tribal area, it's very need to have the childbirthing process and the trainings are very important. So ANM, those who are working in tribal area, we have started with skill birth attendant training. Already we have started in Pravara Institute of Medical Sciences. Our center is recognized by the state Maharashtra board and we have started to give the training to them regarding childbirthing process. How easily the childbirthing process will be there. So in tribal area, we focus more emphasis given for the training also.
And have you seen any reduction or change in maternal mortality since you increased the institutional births? What is the trend like?
Yes, yes, ma'am. We have reduced the maternal mortality.
Mhm. So your paper mentioned 212.
No,
But
that is the Indian scenario. Before that, now only 2 years back only our center has been started, and now we are back of that only to reduce the maternal mortality and morbidity.
right, right. Do you have any figures currently or not yet?
Not yet. We have not yet done the survey. Yeah.
But I must compliment you because that is the area that needs you most, where
Yes,
you're
yes,
working.
ma'am. We are giving more focus on tribal only.
Yes. Okay.
Thank you, ma'am. Thank you so much.
Thank you
Thank you,
so
sir.
Well done.
Thank you, sir. Thank you.
May I announce the second person, Jean and Mala?
Yes.
Yes.
The next person is Aime Boor. I hope I'm pronouncing your name well. And your number is 078, and it's deafness and pregnancy. Extremely interesting area. A service evaluation, including the perspectives of healthcare professional, deaf service users and interpreters, and very interesting.
Mm-hmm. Aimel,
Can you see me?
I enjoyed your study. Are you with us?
She is in the room.
Okay, maybe she's muted.
Sorry, I didn't quite catch that.
Oh, okay. Aimel,
Can you
we
hear
enjoyed
me?
your study.
Hello?
Yes.
There you
Yes.
are.
Yes. So we enjoyed your study on a very specific problem of deafness in pregnancy. And I was wondering, my limited experience of looking after deaf women, I have relied mostly on their home partners because they understand them the most. And if they are their birthing companions, and in some cases it's the mother or a sibling or a partner, did you rely on partner support as well while the midwife took care of the deaf woman?
Okay, so I'm a medical student, so I've not actually been involved in any kind of particular case as such, but I have heard of several instances where people have used family members, but it's not always appropriate. For example, at UCH where I did my study, I think they used a 12-year-old daughter to interpret. And actually, I feel a lot of the time, family members just want to be there as a family member rather than kind of a functioning person who has a job to do.
I take your point. I guess it depends on what relationship you're looking at. A daughter is probably not the most appropriate. So,
Can I just ask a practical question
mhm.
in this? So we always face the challenge when we're dealing with people with different kinds of challenges themselves, how we structure the services to address them. And certainly in my context, we deal with people with different languages and they have various forms of translation. How does that work for, you noted one instance of relying on other family members, but how do you do it as a system so that it's not a matter of asking some 12-year-old to serve as a translator?
Well, I think the best way to do it really is using professional interpreters who are trained, which in the case of UCH, where my study was based, that was kind of Language Line Solutions, which is an interpreting service booked through the hospital. Is that, I'm not quite sure what you were asking, sorry.
Well, you can't necessarily hire translators for every language or every challenge, like use of sign language or lip reading here. And so the question is, institutionally, how do you support that in a way that's feasible and cost effective?
Mhm.
Well, another thing to talk about is video relay interpretation. And it's done on kind of smartphones, or some hospitals have machines installed. And that would be a way of kind of getting more languages, because there are over 200 types of sign language. And I guess it would be a good way to kind of enhance access there. However, the best form is having in-person interpreters. And research and studies have found that that is really what helps deaf women with their anxiety, and that's the best form of kind of providing interpreters for them.
Okay, you mentioned that the biggest hurdle during COVID was the inability to lip read because of the masks that everyone was supposed to wear. And I was just wondering if there are any uses for a transparent mask to be designed where lip reading is possible, but that's just on a lighter note.
Yeah, I have seen mask designs where they do have kind of a clear space here, so deaf people who do use lip reading can see better. However, there are lots of complaints that when you breathe that they steam up, so actually the design isn't optimized yet, unfortunately.
Mm-hmm. Right. And you did mention that there were a number of different sign languages people use. And I think we need to have a uniformity if we want to have protocols and seamless, care, a uniformity of sign language that should be adopted by both the patient and the interpreter.
Well, it's kind of regional. So in Britain, for example, the main form is British Sign Language. So most commonly you will need interpreters for BSL. And actually different sign languages are very different, but I know there are links between, I think, Britain and Australian Sign Language, whereas American Sign Language is very different. I think having one global form would be quite a challenge.
Yes.
However, there are global signs which that everyone can use, like for basic signs.
Okay. Thank you, Aimo. Thank you for your time.
Thank you.
Can we go over to the next one? And the next presentation is 119,
Yes.
Anna Jones, and it's Project 20, the specialist model of maternity care, improve maternal and neonatal clinical outcomes for women with social risk factors, a prospective observational study. Hannah, can you unmute your?
Yes, yeah. Hi, can you hear me okay?
Yes, Hannah.
Yes.
Hi.
So according to you, Hannah, which models would help these women, the community or the hospital model?
So I think overall, we've seen that the community-based models have quite a few additional benefits, particularly those interesting outcomes around neonatal outcomes, so preterm birth, seem to be much
Yes.
improved with the community-based model.
And you mentioned that the hospital models had more low birth weight.
Yes.
Yes, is that because of the anxiety of visiting a big hospital? You think?
Yeah, I think so. So the qualitative data seemed to show that women experienced much more anxiety around visiting the hospital and not being listened to once they were in that large institution, and kind of more discrimination and stigma once they had approached the hospital.
I wanted to ask your opinion on why don't we club the two models and have like majority of the care at the community and maybe a visit to the hospital as and when needed, if complications arise, kind of have more seamless transition between the two models, and that would then be a win-win situation.
Yeah, absolutely. I think one thing that really helps women, in particular these women who have quite complex social histories, is if their midwife, if a known midwife can go with them to the hospital environment, whether it's one named midwife or just somebody that they are familiar with from that team, not only for labour but for their appointments with obstetricians. It seems to be really, really helpful, and women want it.
And that is feasible most of the time, isn't it?
Yeah, it seems to be. I think the difference, another difference that we looked at with these two teams is that one provided care from kind of one named midwife and the other provided care from a team of midwives. And it's certainly more feasible with the team of midwives because there's simply more flexibility there. So I think that's quite an important policy implication because it seems to be much easier to roll out.
I totally agree. The team-based models are a win-win situation for all, I guess.
Yeah, and I think the women that we interviewed had perception of kind of more continuity with that team as well, because they did express quite a lot of anxiety when their named midwife wasn't on call or perhaps wasn't around, and they felt uncomfortable about approaching other members of the team.
So the challenge becomes integration. Dr. Aurora asked my famous question, which was how do you integrate the two? But if you're going to think about team midwifery, then it's a challenge, right, between the respective midwives to ensure that the same message is coming through across. Because my experience in interviewing women is oftentimes I'm being treated by a team and I like persons A and B, but please God, I hope I don't have to deal with persons C and D. How do you structure this in a way that will allow people to be comfortable throughout the team?
Yeah, I suppose that it is helpful for women to have some kind of choice over the midwives that they do see. I mean, these teams, women still had a named midwife, but one of the teams had an emphasis on the women getting to know the whole team through coffee mornings, antenatal care. So I think if they had the opportunity to develop some kind of trusting relationship with at least one of those, hopefully they would be able to express concerns if they did have any about other members of a team. And I think what's important is the size of the team as well. Right. I think women need to still be able to get to know a team. I don't think it works if you have a team of perhaps more than 7 or 8 over a pregnancy.
Well, it's the balance between keeping the midwives from being overwhelmed by it with a really small team and that pressure. What's the mix? I've always heard 6 is sort of the sweet spot of the balance.
Yeah, I mean, these two teams both had 6 midwives. What seemed to really help was the community-based team seemed to have less of a workload because they knew their small community much better. So things were much easier. They could refer people to services, local services that they knew and familiar with, much easier than the hospital-based midwives who had a huge catchment area and felt quite overwhelmed with the services that were available in that area, which seemed to take up a lot more of their time.
That's it.
Yeah, I was going to say I could keep going, but I want to respect the time of everybody involved.
Mhm.
Thank you.
Thank you, Hannah.
Thank you very
Thank you.
much.
Thank you.
Thank you, Hannah.
You're muted.
No, sir.
Unmuted. All
Yeah.
right, I'm going to say it all over again. The next one is Miranda 167, public involvement and engagement with an analysis of births in different settings by the time of day and day of the week using linked data.
Hi.
Hello, Miranda.
Hello.
What an amazing study that you put forth.
Thank you.
It carried me off my feet. And I think what was interesting is the natural rhythm you have shown of normal deliveries at home. They also follow a circadian rhythm, which I was not aware of. I don't know whether Dr. Jean was aware of that. And it is a
I
huge.
actually presented on this at an earlier normal birth conference about 3 years ago at Grange River Sands on just this issue. So I'm fascinated by this topic.
Oh, great.
Really? Yes, of course, the skewing of data in hospital deliveries due to induction is all pretty obvious. The flattening of the curve, the peak timings of delivery at the most convenient time of the day. I think I was impressed by the number of records you studied. It is a lot of hard work, 7 million records that you mentioned.
Yes, there's a big team doing it.
Yes, and extensive data analysis to link the records and get to the right information. I wonder how much the linking would cause loss of data, or could there be a chance of error if you're linking 3 databases?
Yes, I mean, I didn't do this personally, but there was a lot of quality assurance, and it was possible to look at some patterns with all of the data, and then some. Obviously, we lost data when we were linking to the hospital statistics. You lose a certain amount of births through quality, and also particularly the home births aren't included. But if you compare certain factors with all of the births and then the more restricted data set, they showed very similar patterns, which was very reassuring.
And I think I was very happy to see that you had asked your women whether they were comfortable with data use, and they said yes. I think that was also a very positive point of your study. Of course, the results of your study do matter. I think it is a chance for the hospital practitioners to look at their practices and see why are we introducing so much bias into this time of birth due to quote unquote convenience factor, if you can put it that way.
Yes, I think one of the really interesting things was the difference between the home births and the spontaneous births within hospital. So essentially, there may have been some interventions between not having induction and having a spontaneous birth. But even so, this flattening of the curve was sort of slightly unexpected. And I was listening to Susan Crowther yesterday talking about the mood of the birth setting, the mood of the birthing place space. And I just wondered if maybe that was having an effect on, and also Sarah Fadham's talk about autonomy of women in home birth, and whether these factors were actually feeding into the women in institutional settings who were less able to be themselves essentially in that different birthing space that wasn't their own.
I was actually struck by how close it was on the spontaneous birth to a more natural pattern.
I think US timings of births are quite different, and
They quite really are. Yes. Yeah,
Yes.
that's not the case for the United States at all. The question becomes, though, to what extent are the institutional settings willing to adjust to what might be a more natural pattern of things? Because clearly we've industrialized birth. I mean, that's the point of all of these studies that we've done, and Ali and you have done. It's that we've changed the whole process to make it more convenient for the institution.
Yes.
Any
and-
sense that institutions are going to change because of this?
Well, I mean, there've been lots of great presentations over the last couple of days, haven't there, about, you know, the birthing environment, about the mood of the organisation, and I think it is these things that have got to change, isn't it? This non-industrialised approach, the personalised approach, the environment, the ability to, I think I said at the end of my presentation, to sort of create these this sense of intimacy, lighting, not intruding, not interfering with the process of birth. I mean, it's an aspiration, isn't it?
It's a tough call for the institution, certainly. But I like the idea somebody presented of having a skylight and more nature to look at in hospital delivery rooms, which again is a tough call for institutions. But at least you've set a benchmark which the hospital will aspire to achieve. It may not get there, but there is some kind of a benchmark set. Yeah.
Do you get any sense? I was also intrigued by the fact that you actually went out and asked people about their involvement in this, which we never do. And do you have a sense of what would be the barriers to women saying yes? They seem very, I don't want to say compliant, but supportive of what you were trying to do. When are they not? In other words, what are the kinds of things that would bother them about using their data in this fashion?
Well, I think it's been a big issue in this country over the use of data, and particularly what we had the care.data issue, where the public, there was an outrage really about the use of data, particularly for, you know, by more corporate institutions. So I think people are very wary, but they trusted us, and I think because we were talking to them, they felt much happier.
Thank you.
Thank you.
Thank you very much.
Nina and Marla, there is one question that I've put up into the chat box. If you can, and it's Miranda 167. So it has come up through the survey, so I just put it up here for you.
Yes, I'm not sure that it was actually for me, because it was about body mapping, which I think might be covering.
Yes, I didn't quite get that. But are you able to give your views on this?
It's not really my field, because it's about body mapping, which I think is
It is
not my topic. I'll leave it for her.
Okay, thank you.
Thank you.
Yeah, that is. We'll come to that.
Thank you so much. Thank you so much. The next person is Kaveri Myra, 171. Breaking the silence around obstetric violence, women sharing good and bad birth narratives through body maps in Bihar, India. Kaveri, are you here? You can unmute your mic and join.
I am. Can you see me and hear me now?
Yes, Kaveri. Yes.
Hi. Thank you. I heard body mapping, and I wanted to say yes. I think that's mine.
Yes.
So yes, that's my presentation.
So very brave and enterprising of you to go down and try this kind of body mapping. I think not an easy thing to do in an Indian village in Bihar. So you were dealing with 36 to 86% institutional birth rate, which is a huge range, isn't it?
It is. Well, that's for the whole state, right? And it was basically to decide where I should go talk to these women, even though whichever district, whichever block I went to, I would have found similar stories, and I would have found the kind of diversity I was looking for as well. But I think the range and the difference in institutional birth rates kind of helped me decide to pick these two districts and where to go to the data collection.
Mm-hmm. So you could, Dr. Jane, you want to ask a question, or we also can ask her the chat box question?
Why don't we do the chat box, since they really get a chance to speak? We get funny.
Yes. So you've read that question, Kaveri.
I don't have access to the chat box right now. I'm sorry.
Oh, Nusrat, can you please read it out to us?
It says, I'm a psychiatrist, psychotraumatologist, and I'm doing my research in birth trauma and obstetric violence field. In your experience, are there any differences in body mapping depending on how many traumatic childbirth did the woman have? The body remembers and stratifies all the memories.
Well, I think you have said it yourself. There is quite a bit of discussion on the recall period, and especially when we do quantitative surveys, we always want to narrow it down and limit it to a recall period for the person who has given birth, to say that, you know, we don't know whether this person will remember or not. How do we trust that this person has remembered what happened then? But I have met women who have given birth over 30, 40 years back who clearly remember what happened. Yes, what they might forget is the details of, you know, which arm you might have gotten an injection in. But especially when it comes to trauma, especially when it comes to violence, they never forget it. And for my study, I did have this criteria that I will meet women who have given birth at least in the last 3 years. But most of these women have given birth more than once. And the idea wasn't to talk to her about the latest birth. The idea was for her to decide which birth is it that she wants to talk about, because these are 7 feet long sheets of paper, right? So it's very open ended. We talked about every childbirth experience she had, but one main birthing experience will be displayed on the map that we will work on. But we talked about absolutely everything. It was very open ended, and the person decided what course this discussion will take, and over several interactions, because I met around 2 to 5 times. I went to their houses and spent a few hours every time with them. So, you know, that changed with how trust developed, and they opened up more. And sometimes their narratives of what they said good in the first interaction changed in the third interaction, because now they thought, okay, I can talk about my bad experience now. I can talk about the abuse I have felt now. And you need to develop that kind of trust for stories like that.
Is there any cutoff for the recall period set out for, by people to say that it should be within this time frame to be more accurate, or there is no recall period set?
Well, like I said in my previous response as well, in quantitative research, we try to nail it down for a recall period, because then, I mean, you can generalize it better. But the beauty of qualitative research is you want to understand the context, you want to understand different other aspects of this person's life as well, which would have made her more vulnerable to go through the abuse that she did when she was giving birth. So I have been part of a survey previously where we kept the recall period to 30 days, but we had observed the birth of these women. There were thousands of women, and then we took consent to go back to their house within 30 days, because we wanted to see and compare between what we saw and what this person felt. So it depends on the objective, that, you know, what exactly are you trying to see. But honestly, for my study, the recall period did not really have an importance.
In doing this research, you're obviously dealing with very traumatic issues for the women that you're working with on this. And you touched on this briefly, but can you talk a little more about, and so what happens after you're done? After you've worked with them to identify these experiences, where we leave these women now that they brought what may have been beneath the surface for a long time to the surface? So
the thing is, I didn't go to these urban slums and rural villages looking for traumatic birthing experiences. There was no particular criteria that, you know, if you have been disrespected or abused, or if you have gone through obstetric violence, then I will hear your story. The only thing was, to go ask these women, if you have given birth, would you want to talk to us? And this is time consuming, it's going to take this much time. And surprisingly, all these women that I spoke with, everyone had been through a traumatic childbirth. But I understand there is a dearth of good birthing stories, stories of birth that have been pleasurable, that have been encouraging, that have been happy. So the idea was to see even women who are very happy with their birthing experience, what has their experience been like? As you might have seen in the first birth mapping, which is at home, and she's squatting, and it's very simple. It's not very crowded. That map is very, simple. But other than, even with that woman, she had gone through 3 traumatic childbirths, but she chose to show the happy birth, her 4th birth, on that map. And more about it comes out in the analysis when it's written down, or when you read the birthing stories. But yes, you're absolutely right. These are some of these questions that they don't feel like they should talk about, and there is no culture of talking, which is why there's the silence about birth, and not just traumatic stories, but any kind of stories. And the satisfaction that I have seen in each of these women's, sorry,
Kaveri, we are running late, so we'll need to stop here, please.
Yes.
I understand. Can I make just one point, that these women had addresses of therapists that we carried with us. So in case they wanted to get in touch, then we were capable of putting them in touch.
Okay.
Thank you so much for your questions.
Thank
Great,
you.
thank you.
Thank you, Kaveri, for that wonderful presentation and an interesting study. Thank you, Dr. Jeena and Dr. Mala for judging the session. And we thank each one of the authors as well as the judges for this session. And we request the judges to send in the score sheet as soon as possible, because we have to collate it. And for all the authors, the results will be announced by 8:10. So please watch out for it. And thank you so much.